Hello everyone. So I am Dr. Puuja Arora, mentor and director of Just MRCOG, a key to success in Part 3 MRCOG in one go. In this video, I'm trying to simplify FGR and SGA new guideline. Let's begin with what we are going to cover in this session. Its definitions, types, what are the risk factors, how you are going to perform surveillance, what are the measures to prevent FGR and management once we diagnose particular fetus as FGR or SGA. Let's begin with definitions. What is the definition of FGR? That is fetal growth retardation. When estimated fetal weight or abdominal circumference is below third centile or when estimated fetal weight or AC below third centile or estimated fetal weight or AC below 10 centile with Doppler abnormalities. Means when there is below third centile, we do not need any other feature. But when it is less than 10 centile, then there has to be Doppler abnormalities to consider it as FGR. FGR in current pregnancy. Same if estimated fetal weight or AC below third centile or estimated fetal weight or if AC, that is abdominal circumference, below 10 centile with Doppler abnormalities, or there is one more criteria when growth crossing 50 centile means it is dropping down. When we see in growth chart and we compare between two growth and the growth interval is showing that there is growth decreasing with 50th centile. So what are the Doppler abnormalities which we count? Doppler abnormalities normally indicates placental dysfunction. Abnormal uterine artery Doppler means PI above 95th centile and or abnormal umbilical artery Doppler, either there is absent, reversed diastolic flow or PI 95th centile. So how we are going to remember this? It's very easy. When is third centile, we do not need any other feature. When 10th centile, it has to be some Doppler changes. And when there is growth declining almost 50 centile. In Doppler abnormality, which normally indicates placental dysfunction, there could be two types of abnormalities. Either abnormal uterine artery or abnormal umbilical artery Doppler. Okay. In abnormal uterine, the PI above 95th, same for umbilical if PI above 95th centile. Other than that, if there is any absence or the reversal of diastolic flow. So if we find any of these four, abnormal uterine artery Doppler, that PI 95th, abnormal umbilical, then again PI above 95th, or absent or reverse umbilical artery Doppler. So any one or more than one then we consider it as Doppler abnormality. Most frequently associated with maternal hypertension, and this occurs in 70% of early onset of FGR, right? So FGR is most frequently associated with maternal hypertension. 70% of early onset FGR hypertension is responsible. So when we suspect FGR, when there is suboptimal or reduced growth velocity, or when there is static growth. And when we confirm, when there is drop of more than 10 centile in estimated fetal weight or abdominal circumference. So these are the other parameters. I have included this parameter in definition as well. So when there is drop of this much between two comparison, then we consider it as, or we diagnose it as FGR. Now FGR in previous pregnancy. FGR in previous pregnancy is a very important risk factor, so you should know when we call it as FGR in previous pregnancy. When birth weight below third centile, same, birth weight below 10th centile with placental dysfunction. So what is difference between current? In current, it is going to be estimated birth weight or estimated fetal weight. Here it is going to be birth weight because baby is already delivered. Rest, this and this is absolutely same in both. Other than that, birth before 34 weeks in view of early onset preeclampsia, birth before 34 weeks in view of FGR. So birth before 34 weeks in view of preeclampsia or birth before 34 weeks in view of FGR. So this is criteria of FGR in previous pregnancy. Third centile, 10th centile with this thing. 34 weeks delivery. Before 34 weeks, this because of this or because of this. Types of FGR, there are early onset. When it is less than 32 weeks, it is diagnosed. Late onset, when it is diagnosed after 32 weeks or more. What is early onset? The first criteria, which we have already discussed, less than 32 weeks. And there is no congenital anomaly. So less than 32 weeks, no congenital, anomaly. So that is the first criteria, right? And that is associated with, again, same AC or EFW less than 3 centile, AC, EFW less than 10 centile. Whenever there is less than 10 centile, there are certain associated features like uterine artery PI more than 95th, umbilical artery, more than 95th percentile. So less than 32 weeks and no congenital anomalies, first thing. And with this, if we have one of these two, either AC or estimated fetal weight less than 3 centile, or AC or estimated less than 10 centile, but with PI umbilical or PI uterine, it has to be more than 95th centile. Other than that, there is one more, that is umbilical artery has absent diastolic flow. So how you are going to identify early onset, less than 32 weeks, no congenital, if less than 3 centile, if less than 10 centile, with uterine artery or umbilical artery, PI more than 95th, or if there is absent diastolic flow in umbilical artery. So then we are going to call it as early onset FGR. So when AC and EFW is 10 centile, then PI criteria, right? But absent diastolic flow is an independent criteria. So basically, when 32 weeks, no congenital anomaly associated with either this, with this, or with this. Absent diastolic is an independent criteria, even if we do not have this, even if we do not have this, but if we have absent diastolic flow before 32 weeks, it is early onset FGR. Clear? So this is consistent, either this or this or this. And this is always with extra Doppler feature. Always remember, less than 10 centile, always with an extra Doppler features. Late onset, when it is more than 32 weeks, no gross congenital anomaly. Now again, ACFW less than 3 centile, ACFW more than 10, less than 10 centile. And then I always say, whenever there is less than 10 centiles, it has to be associated with other features. So here there are three features and one can have any two feature to confirm late onset. So when AC and EFW crossing centile more than two quartiles on non-customized growth centile. So you remember when crossing two more than two quartiles is one criteria. CPR, cerebro-placental ratio, when less than fifth centile. Umbilical artery VI, when more than 95th centile. So this is the criteria for. So when we call late, when it is more than 32, no gross congenital. It is absolutely same like early. It is only 32 weeks less, 32 weeks more is late. There is no congenital anomaly in both. 3 centile in both, 10 centile with extra feature in both. So what is extra feature here? CPR crossing two quartiles and umbilical artery more than 5. So this is also there here. See? So this thing easy to remember. This you have to memorize. This you have to memorize. And this you have to memorize. Either 3 centile or umbilical artery or 10 centile with increased PI. What is late onset? When more than 32 weeks, no gross congenital. ACFW 3 centile. ACFW less than 10 centile. And 10 centile, we have to have extra features. So here extra feature is PI, CPR, and more than 2 quartile. Now small for gestational age. When fetal size is less than 10 centile at single time point in pregnancy. And how we assess fetal size? By biometry, that is head circumference, abdominal circumference, femur length, separately or combined as estimated fetal weight. Refers to fetus with a predicted weight or an abdominal circumference less than 10 centile. It's one of the same thing. HGA, there is normal growth velocity, there is normal Doppler study, there is normal fetal movements, and there is normal amniotic fluid. So basically, it's only fetal size which is off track. The rest, all the parameters are normal. It is simply what we have learned so far. This is the graph, 10 centile, 9 centile. This is appropriate for gestational age. This is large. And this is small for gestational age, where there is no other abnormality. Everything is normal. Everything is normal. How to distinguish between SGA and FGR? Definitely Doppler velocity of uteroplacental circulation. This is what we have just read because there is normal Doppler, there is normal growth velocity. So what is the difference? Difference is velocity of uteroplacental circulation. So definitely in SGA, this is going to be normal, but in FGR, this velocimetry velocimetry of uteroplacental circulation is going to be abnormal, then this is FGR. Some growth restricted fetus or infants are SGA. Likelihood of FGR is definitely higher in a smaller size. Basically, when there is baby small, more chances of FGR. Simple. Growth restricted fetuses have evidence of fetal compromise, like abnormal Doppler, just a minute, abnormal Doppler and reduced AFR. But obvious, that's the only difference between FGR and SGA, no? Both are smaller in size. Both are restricted, but here in SGA, there is only sign is of fetal size. The rest, no Doppler problem or other features. But in growth restricted, we definitely find other features like abnormal Doppler and reduced AFI. Static growth, earlier we were considering it 21 days. Now, when there is no forward growth velocity in estimated fetal weight or abdominal circumference measured at least 14 days apart. Means when you have two measurements at interval of 2 weeks and the growth velocity of estimated fetal weight or abdominal circumference or both, we can take one criteria, whatever is there, or even both is there. When there is no growth velocity, it is absolutely same what it was today and what it was after 2 weeks. Then we consider it as static growth. For fetal growth assessment, minimum 2 assessment of fetal size. It's obviously you can only compare, no, to estimate growth velocity minimum 3 to 4 weeks apart. So definitely if you want to understand or determine the growth assessment, then you have to compare, no? So you have a criteria that you have this. Now after 3 to 4 weeks, you have again performed it and you find that there is no appropriate growth. So for fetal growth assessment, minimum 2 assessment of fetal size. This is a common sense. And what should be the difference? 3 to 4 weeks apart. It also includes when we talk about fetal growth assessment, it's not only the biometry, it also includes additional informations like but maternal history, symptoms, AFI, and Doppler velocimetry. Velocimetry. Okay. Now the risk factors. Risk factor for FGR, booking and SGA both. Booking, maternal condition, antenatal, risk developing in pregnancy and current pregnancy. So we will discuss all the headings one by one. Risk factors, we always assess risk factor by 14 weeks for all FGR. This is very important SD question and this is very important SPT question because if a patient has come with a fear of having FGR because she is a smoker or whatever it is, and she has come at 12 weeks, then you will say that we are going to assess you by 14 weeks or within next 2 weeks for FGR or growth restricted baby. So what we all take in account? Birth weight and what was the birth centile and what was the gestation for all previous pregnancy means their previous deliveries birth weight, what was the birth centile and what was the weeks of pregnancy that we all going to mention at booking appointment. And then we are going to offer her customized plan for the assessment based on the specific combination of risk factor. So once we do the risk assessment at 14 weeks, then on the basis of this risk factor, we offer the customized plan for the assessment based, right? And then we have to inform women that we will offer her targeted tests like uterine artery Doppler or and or serial ultrasound surveillance. So at 14 weeks, we are going to assess her by 14 weeks and we check previous birth weight, centile, and weeks of pregnancy when she delivered. And then on the basis of this risk factor, because we are going to do this risk assessment, on the basis of this risk assessment, what is the level of the risk she has, that is high risk, moderate risk, or low risk, we are going to offer her a customized plan, right? And we will also inform her that she might be offered with some targeted tests like uterine artery, umbilical artery, or serial ultrasound. So now, as we have discussed here that we have these much risk factors. So very first is booking. Previous FGR or SGA, previous stillbirth, previous preterm, previous pregnancy loss, previous placenta mediated complication. So I make it easy for you to remember. First, remember previous FGR, SGR, FGR and SGA. So it eventually caused pregnancy loss, right? So previous FGR, SGR and previous pregnancy loss, right? If not pregnancy loss, then probably previous preterm. If not there, then stillbirth. So FGR, SGA, then pregnancy loss, then preterm, then stillbirth, and pregnancy placenta mediated complication. Previous pregnancy with placenta mediated complication. Now, medical condition: diabetes with vascular disease, moderate and severe renal impairment, especially with hypertension, antiphospholipid antibody syndrome, chronic hypertension, SLE, complex congenital heart disease, and or ventricular dysfunction, NYHA class 3 and class 4, anticoagulant use, beta blockers that include all LOLs, labetalol and other LOLs. Maternal age more than 40, 40 or more than that. BMI less than 18, ideal is always 20 to 30. It's not 25.6, 24.6. It's always 20 to 30 and poor weight gain in pregnancy. Obesity is not a risk factor per se for FGR or SGA. Remember that it's less BMI which is more dangerous. So these are the criteria. Remember that it's less BMI and poor weight gain. Now risk factor, antenatal risk. So this is basically lifestyle, alcohol. One drink per day or doubling the risk with 4 drinks per day. So whatever risk she has with 1 drink per day, that will double if she takes 4 drinks per day. So ideal is drinking 32 grams per week or less. That is 2 UK units up to twice per week. 2 UK units up to twice per week. Pre-conception alcohol consumption also is. Basically, she should have alcohol-free environment. But still, if she is not able to discontinue, then you should offer her that 2 UK units up to twice per week is still have some chance of having a healthy pregnancy. Drug abuse, especially cocaine and especially crack cocaine. This has high risk of SGA. Marijuana causes the placental dysfunction, So it goes. So basic thing you have to understand, whenever there is placental dysfunction, more chances of FGR. So marijuana is completely should completely avoid. Smoking. Again, patients should have smoking-free environment because smoking affect dose dependent more with elderly. It is dose dependent means how much you are taking, and with elderly, more in elderly. And throughout the pregnancy, if she smokes, it doubles the risk of SGA. So alcohol, drug abuse, smoking. So drug abuse and smoking both is responsible for SGA. Smoking also responsible for preterm delivery of SGA with FGR. But you have to counsel her that stopping by 15 weeks reduces risk similar as to non-smoker. Less than 18 BMI and simultaneously she is having any eating disorder. Medical condition which is affecting her nutrition, like any renal, gastrointestinal, lymphatic, cancer or COPD. Bariatric surgery. Bariatric surgery also a risk factor, but we know that there are two types of bariatric surgery. One where there is malabsorption, that is gastric bypass, and second is restrictive when there is gastric band. So gastric bypass is more at risk for FGR or SGA. So we offer ultrasound surveillance for gastric bypass. Ethnicity, Southeast Asia, African, etc. are more risk of FGR or SGA. Congenital uterine malformation more with like septate or other bicorporeal uterine, that is also responsible. So in a recurrent miscarriage, if there is any congenital uterine malformation, and when you reach to second part of the task, then you will say this is also responsible for FGR or small gestational age. So we are going to offer you a repeated or monitoring of fetal estimated fetal weight or fetal size. So this is you are going to, because patient is coming with recurrent miscarriage, right? So how you are going to monitor her? Caffeine maximum 200 milligram per day. That 2 mugs of instant coffee, 300 mg or more, responsible for SGA, especially if she is taking it in the last trimester. Risk developing in preeclampsia, that is gestational hypertension, 160, 110 or more, chronic hypertension, preeclampsia, mild hypertension, if clinically indicated. COVID-19, if patient is having or was having COVID-19, so once she recovers, then within 14 days of recovery, we offer fetal biometry. Okay, within 2 weeks. APH. APH is a risk factor and indicates serial scan for fetal growth, right? APH with abruption, or if if there is APH with abruption, APH is very much possible. With placenta previa, APH is possible, or when there is no diagnosed cause for APH. In that case also, it is considered as risk factor. But if there is placenta previa, but there is no episode of bleeding, so placenta previa per se is not a risk factor for FGR. Now, in current pregnancy, we have offered her certain biochemical markers, which we do in second trimester or first trimester screening, that we do double marker or quadruple marker. Low PAP, that is indication of stillbirth owing to placental dysfunction, SGA and FGR. So low PAP is dangerous because it causes SGA, it causes FGR, it also causes stillbirth. High AFP, alpha fetoprotein or inhibin A. It both responsible for SGA and FGR. If this is low, then SGA FGR. If this is high, then FGS. And that normally we do either in first or second trimester. In case of low PAP and high HCG, we always offer aspirin. Low PAP and high HCG. So now this is certain courses which we are offering. That labor ward we are going to start from 1st of December. Everyone will present all the rooms in Telegram and everyone is going to get the feedback and it is on the daily basis. Then we are going to have live session 1 in 6 to 8 days when again we are going to have rooms presented by the students and I'm going to give feedback and we are going to discuss answer keys. I can proudly say that my answer keys for labor ward are extremely admired by a student. Second is unique. This is a course which is very close to my heart. That is one-to-one live sessions. The Zoom session which we conduct every week and we take module-wise session. So in first session, if fertility, then all tasks to that. If fourth session, urogyne, then all tasks related to that. 50 recalls covered means in unique course, you are going to present 50 recalls to me one-to-one. Answer keys for all recalls, but you are going to get answer key for 200 or more than that recalls, either written or audio made by me. There is huge voice library for all the recalls by the star performer. So in each channel of module, we have 3 sub-channels, like my answer key for all recalls, that is also fertility, then huge voice library for all recalls of fertility, and then third is study material. Okay, so that is going to be for each module like fertility to urogyne to antenatal. Next, this I have recently launched on demand of a student, that is AIM MRCOG long course, that is for 16 weeks, and that is live session course. It is not a Telegram course. 6 active students. They are going to cover 96 recalls. Each student is going to present 16 recalls overall in 16 sessions. So one student, 16 recall, overall 96 weekly session, and recording will be available. Additional feature with this is again channels for each module separately, and each module 3 sub-channels, my answer key, second channel voice library, and third channel is study material. What are the course fees for unique? It's 80,000, 16 weeks. Exclusive labor ward, gynae ward is 15,000, 12 weeks course. And AIM MRCOG 16-week live session, it is 70K INR. This fees I'm mentioning in Indian rupees. So you can convert in your country's currency to understand how much it's going to cost you. Now I have this combo of offer. This is an offer to clear part 3 in one go. Clear part 3 in one go. This is a combo offer. This is very economical and more than economical. This is complete course which you need to clear this exam. You are not need to look here and there. So what is that combo offer? Complete course to clear in one go. And I can guarantee you that. Unique is for 80,000, labor ward for 15,000. And after completing this, close to exam, you will have on-site, online 7 station. So it's 1,06,000. 96,000 is net payable. And that is on demand of a student time, making it till 15 November night. AIM MRCOG 16 week, that is the live session for 70,000. Labor ward again 50,000. Online again 70. Overall is 96 and the payable is 86. So these are the two combo offer. Once you take this combo offer, you are not supposed to take any other course or anything. This is absolutely complete course. Now, coming back to FGA and FGR and SGA, how we perform or how we do surveillance. Symphysis, fundal height, uterine artery Doppler, and surveillance chart. What modalities we use? 3D ultrasound, fractional limb with 2D MRI, and computerized CTG. CTG details. Computerized CTG preferred over conventional one. Why? Because visual inspection of conventional CTG is subjective. So your interpretation can vary from my interpretation if we go for conventional. So we always prefer computerized CTG for FGA, FGR, or SGA. FHR STV, short-term variation. Fetal heart rate short-term variation is a biophysical parameter obtained by computerized CTG. And here, this STV, the short-term variation, can reflect if baby who is FGR and having hypoxia, right? So this is the biological parameter. Any change in this can reflect hypoxia, that FGR baby is having hypoxia. There are certain biomarkers like placental growth factor, we call it as PLGF, or soluble FMS like tyrosine 1, either measuring it individually or separately or taking a ratio to diagnose preeclampsia. This is basically helpful in diagnosing preeclampsia. Why it is important here? Because FGR is strongly associated with preeclampsia and placental dysfunction. And this show us placental dysfunction. So ratio is PLGF slash SFLT1. Now, what is low risk and FS? When there is no risk and or the patient is low risk, then we offer symphysis fundal height measurements. This serial measurement of SFH as each antenatal after 24 weeks, not before 24 weeks. And the interval should be between two measurements at least 2 weeks. First measurement should be carried out by 28 weeks. It's a myth that we do from 24 weeks. No, we perform by 28 weeks. And if we are not able to do because of any reason, then you have to do it at 34 weeks. So routine assessment at 26 to 28.6 with 28 weeks appointment. So we do it after 24 weeks, but we never start from 24 weeks. Preferred is 28. In certain cases, we do it between 24 to 26 weeks. In routine cases, it is 26 to 28.6 with 28 appointment. But in certain cases, we do it earlier, that is, if there is any maternal condition, if fetal movements are concerned. Maternal condition and fetal movements are a concern. SFH, reasonable tool for growth monitoring in low risk. Very important thing that we consider it as an important tool to measure growth only in low risk patients. Okay. While measuring this SFH, there are certain points. If single SFH which plots below 10 centile, or when there is serial measurement is demonstrating suboptimal growth. Like when you have checked at 28 weeks, then 30 weeks, then 32 weeks, and you think that SFH is not showing increased growth or enough growth. So if there is single measurement which is below 10 centile, or when there is serial management which is demonstrating suboptimal growth, no apparent growth in 2 weeks, means if you think there is no apparent growth in 2 weeks, then we have to refer to ultrasound measurement of fetal size. So when we start 28 weeks, if we are not able to perform, then 34 weeks, and that is the important tools only for low risk. If there is 10 centile below, if there is not able to demonstrate, then we have to offer, if growth, then we have to offer fetal size biometry. Less accurate. There are certain conditions when the SFH is less accurate, like BMI 35 or more, and booking, very important. Large fibroid, polyhydramnios, abnormal live fetal heart engagement, we have to offer a serial assessment. For congenital uterine, we start this serial assessment from 28 weeks. In rest of the cases, we start from 32 weeks. So these are the certain conditions where we do not find SFH very accurate or sensitive. So we always offer serial assessment of fetal size. And in 28 weeks, only in case of congenital. In rest cases, we offer 32 weeks and we offer 4 weeks. Now, when we offer uterine artery Doppler with mid-trimester screening, in case of high risk factor, we offer uterine artery Doppler with mid-trimester screening. So, when our patient is having high risk factor for SGA or FGR, we always offer uterine artery Doppler with mid-trimester screening. And what are those factors? Well, previous preeclampsia, previous FGR, previous stillbirth, maternal condition, abnormal biomarkers. Then in between 18 to 23.6, we are going to offer these two together. Okay. But if mid-trimester anomaly scan showing echogenic bowel, single umbilical artery, or biometry less than 10 centile, so we offer mid-trimester anomaly scan to rule out any physical abnormality head to toe, that is somewhere around 18 to 20 weeks. So if in that scan we find any echogenic bowel or single umbilical artery or biometry less than centile, then we are going to offer her immediately uterine artery Doppler. So in high risk factor, you are going to offer both together, mid-trimester and the uterine artery. But when there is no high risk factor, there is moderate risk factor, or there is something like this, echogenic bowel, single umbilical, or less than 10 centile, you find in mid-trimester, immediately you are going to offer uterine artery. So in high risk, we offer together. If there is no high risk and we find something like this in mid-trimester, then we offer uterine artery. What is moderate risk category? Whatever the risk factor which is falling in moderate risk category, that can cause late onset. And serial assessment of fetal growth at 32 weeks, 4 weeks. Now, high risk category. High risk category can go both early and the late. Uterine artery Doppler performed at the time of routine anomaly scan to determine need of further surveillance. This we have just read. That uterine artery with mid-trimester 18 to 23 when they're high risk factor. This is what they are explaining while discussing high risk. That uterine artery Doppler performed at the time of routine anomaly, right? And if it comes normal, that we have performed between 18 to 23.6, both these two, if it comes normal, then directly we start from 32 weeks, 2 to 4 weekly until delivery. But if this uterine artery comes abnormal, then serial scanning from 24 to 28.6, and we always individualize how frequently we need. So In high risk, it's 32 weeks, 2 to 4 weekly. And in moderate risk, it is 32 weeks, 4 weeks. 32 weeks, 4 weekly moderate. For high risk, is 32 week, 2 to 4 weeks. So in moderate, we offer mid-trimester anomaly. If we find anything, then we offer uterine artery. But in high risk, we offer both together at this week. And in moderate risk, 32 weeks, 4 weekly. And high risk, 32 weeks, 2 to 4 weeks. Okay, so this is easy to remember. Now, investigation in fetal growth disorder, this can be a SD question. We will say that fetal medicine reference when less than third centile or 10th centile with any abnormal. So we are going to give the offer of fetal medicine. Invasive diagnostic test when there is severely SGA with structure abnormalities with normal UTI and non-anomalous means non-vesting we offer when severe SGA and showing structure abnormality, and then uterine artery is normal and non-anomalous fetus. Non-anomalous means there is no anomaly like Down syndrome or something. That is before 23 weeks. Then we always offer microarray. Microarray to detect if there is any micro deletion or micro insertion. Micro deletion or micro insertion. For that, we perform microarray. Either micro deletion or micro insertion. So we offer microarray by offering some invasive testing. And what are the criteria? Severe HEA, structure, normal, abnormal, and normal. And third is parental exome sequencing. If there is multi-system abnormality in the baby or long bones are shorter. So we offer parental exome scheme. So fetal medicine reference, invasive diagnostic, and this. And we offer our serial serology for congenital CMV or toxoplasmosis, malaria, and Zika if they are coming from a high-risk population. Now, risk assessment, screening for early onset tries to pathway, and screening surveillance pathway for it. No risk factor,